Mr. Chairman, is on.
Okay. Good afternoon, everyone. My name is Deng Yulin from National Taiwan University Hospital. It's my great pleasure to welcome you all to the APSC Cloud webinar. I'm honored to be here today as your chair for this section. Please show the slide. Yeah, here is the faculty. And the main topic of today's webinar is comprehensive update management of PVC, VT, and VF from preventive, elective to emergency approach. And this is the annotation of this section. Let me go through it quickly. Ventricular arrhythmia can be either benign or harbinger of sudden cardiac death, depending very much on the underlying myocardial substrate and genetic predisposition. With the highly life-threatening nature of ventricular arrhythmia, management strategies should be important for all cardiologists. In the present section, there will be in-depth presentation on the update topic of PVC burden, arrhythmogenic mitral valve prolapse, ablation in post-infarction, ischemic cardiomyopathy, Purkinje fiber ablation in recurrent polymorphic VT, VF, and percutaneous stellate ganglion blockade in electrical storm of VT-VF. And finally, the ICD indication reappraisal for HFrEF. The series of hard topic exploration could help base decision-making for frontline cardiovascular service. This is me from National Taiwan University. The other chairperson is ex-president of APHRS, Dr. Chakapong Kamukos from Ramati Bari Hospital, Thailand. Next slide, please. Before we begin, here are some quick notes. First, the content of the webinar should not be distributed without the permission of the APSC. And also the views and the opinion do not represent those of the APSC. And the live streaming content of this webinar will be available on APSC Cloud Facebook and YouTube page. So let's get started. 6 distinguished speakers will give talks on this topic. And the first speaker is Dr. Dong Kang Hong from Hugh University of Medicine and Pharmacy Hospital, Vietnam. His topic is systemic management of PVC in structurally normal heart, medical, interventional, or device. Let's welcome Dr. Hong. Dr. Hong, please.
Thank you for the kind introduction. So on, I want to say thank you for the APSC to invite me into this webinar. So let me share my screen. Okay. So good morning, Professor, Doctor, and colleagues. My name is Dong Kang Hong. I'm working at Hue University of Medicine and Pharmacy Hospital, City, Vietnam. Today it is my great honor to present our topic with a focus on systemic management of premature ventricular complex in patients with normal heart, particularly normal heart. And I will talk about the medical intervention or device treatment of the patient. So I have a no disclosure to declare. So further on, I want to talk some basic information about the premature ventricular complex. So as you all know, the PVC could be defined as the abnormal QRS complex with abnormal duration typically more than 120 milliseconds, and the change of T-wave in the opposite direction of the QRS and no P-wave before the QRS. You could see here is a sample of the PVC and with a fully compensatory pause. And for the classification of the PVC, we could have as a unifocal or the monofit PVC. We have, which means that there is only one morphology of the PVC. Or we could have the multifocal or multiform of the PVC, which means that there were many different shape of the PVC, and there could be the sign of many origin of the PVC. And another definition is a short couple PVC, and maybe a long time ago we call it the RR, the PVC on the T-way. So that means a PVC that interrupts the T-way of the preceding of the conductive beat. And another definition is a ventricular tachycardia, which means that there were more than 3 consecutive beats originate from the ventricular. And for the non-sustained BT, it means the run of the consecutive ventricular beat persistent for more than 3 beats to 30 seconds. C is a sample of the run of BT. In my talk, I focus on the PVC in the patient without the structural heart disease. Also, we could call it idiopathic PVC. It is not associated with the structural heart disease or a genetic arrhythmia syndrome. The mechanism of the kind of PVC are mainly the trick activity or the reentry mechanism. To differentiate between the idiopathic PVC and the PVC with associated with the structural heart disease, we have 3 kind of criteria. First is most of PVC originate from a single site and specific region of the heart. And the most commonly is the right ventricle flow tract. Secondly, there were no detectable scar. And the third criteria is usually this kind of PVC is benign, have a benign prognosis. So the ICD implantation is generally not recommended. For the prevalence of the PVC, there were many studies which show that the PVC is quite common even in the normal people. For example, in the ARRHIT study, the percentage of the PVC were 1.8%, and the prevalence of the PVC is increased as the monitor duration increased. For example, at 2-minute ECG could detect the PVC is 5.5% of the population. And in the Framingham Heart study, if the PVC were observed in 12% of the individual with alcoholic disease. And in the 24-hour monitoring in the healthy adult between the age of 25 to 41 years old, at least 1 PVC could seen in around 70% of the participation. Some other study could show that even in the normal health people, the PVC could be seen in 1.01% of the habit. And in another study, the PVC could be seen in more than 99% in the elderly patient. Even in a doctor, we could see that there were a study in America could show that 0.2% of 16 million California residents have the PVC. So what is a predictor PVC? In the study of Carolina TA in 2018, there is a regression and see that in the total population with more than 1,000 people, the age or male or systolic pressure and heart failure and history of myocardial infarction, smoking, or the low ejection fraction are on the predictor of the PVC, with the more percent increase in the lower ejection fraction. So in the patient with PVC, what do we do for the evaluation? Commonly, the patient come to the hospital for detection of the PVC will have a symptom of palpitation, and another symptom including the presyncope, dyspnea, or fatigue. And many patients were diagnosed with PVC on the identically findings that on the ECG. And generally, some patients were diagnosed with the situation with syncope or sudden cardiac death. So how to detect the PVC in the patient. Commonly, the no common statin is a common ECD, and when we want to do the more longer examination, we could use a Hunter ECD 24-hour, or recently we could use a fast ECD, or for longer time detection, we could use a loop recorder. And recently, even the smartphone-based actually could record the PVC. And nowadays, the percentage of people use a smartwatch to recording the ECD more and more people use that. So we could also detect the PVC with the smartwatch. So after we diagnose the PVC on the EKG, the next step is we should find out the origin of the PVC. So normally, the first step, we should assess the PVC have the left bundle or the right bundle brand morphology. So if the SCD shows the PVC with left bundle brand, and the next step we assess the inferior acid, and then we assess the morphology of the create in the V1. So there were many algorithms for localization of the isotope PVC, and this, I will focus on some more common locations, such as the RV1, which shows the LBBB morphology in ferro acid, and V1 in create, and the transition in V4 or V5. And if the transition go to the V3 or V4, it could be the RVO receptor. And another solution is the PVC have a right bundle brand morphology. If you have a superior acid and narrow create, it could be in the left posterofascicular, or if the PVC has a right acid and narrow create, it could be in the left anterior fascicular. And in another common position is in the papillary muscle. So here is some representative EKG of the some of more common location of the PVC. So if the patient has a PVC, what is the prognosis of the PVC affect to the patient? In a study by Purkinje in 2025, he showed that the more there were an association between the baseline percent of PVC and 5-year reduction of LVAF. It means that the patient have a more PVC, more prevalent of PVC will have a reduction of LV function after 5 years, and the patient with more PVC also have the more prevalent of heart failure and the higher rate of mortality. And in a study of Gregory on this, the results show that the PVC in the cardiomyopathy occur at the PVC burden with between 16% to 24%. There were another kind of risk score for the process of PVC. We call the ABCVT risk score, including the acid superior 1 point, the burden more than 20% is 3 points, and the coupling interval more than 500 milliseconds have 4 points, and if person have a VT have 4 points. So upon it, so if the patient have a more than 4 points, will have the high rate of adverse event, including the composite of cardiovascular mortality, the reduction of LVAF, or heart failure hospitalization. And they also validated score in a Korean population, which shows that the patient with this risk score more than 4, he have the worse outcome. So they are the factors related to the PVC-induced cardiomyopathy, including the MACE, asymptomatic PVC, the longer duration of PVC, the interpolated PVC, and the variable PVC coupling interval, longer PVC QRS duration and PVC arrive from the epicardium. So after the assessment of the PVC, the question is when to treat the patient. So the treatment of the patient with PVC depends on the first, if the patient has a symptom or not. Secondly, the burden of the PVC, which means the percentage of the PVC. And the third one is the presence or absence of the structural heart disease. So this is a guideline from the ESC, from the ESC guideline 2022. In my topic, I focus on the patient with normal heart. So if we could assess it with idiopathic PVC or VT, if patient have a symptom, and if the morphology shows the RVRT of fascicular PVC, the first treatment is a catheter ablation and with class 1. And if the patient prefers a medication treatment, we could treat the patient with beta blocker, calcium channel blocker, or blockade. And if the location of the PVC is not from the RVRT or fascicular PVC, the treatment with the beta blocker or calcium channel blocker is class 1, and the catheter ablation is class 2A. And if the patient don't have the symptom, but if the patient have more than 20% of PVC, we should follow up the patient with LV function. So in patient with the PVC burden more than 10% and the reduction of the LVF, if the problem is how could we know this the reduction of LVEF is because of the PVC or because the patient have no structural heart disease. So if the patient don't have the structural heart disease, we check for the coronary artery disease, valvular disease, or inflammatory heart disease. So if patient don't have a structural heart disease, we do the cardiac MRI. And if the patient shows the late cardiac enhancement, and the patient have the degree of heart function by the PVC, the patient should be treated with catheter ablation or amiodarone with class 2A, and give the patient were suspected PVC-induced cardiomyopathy. The catheter ablation were class 1, and the use of medication for anti-arrhythmia is class 2A. So here is another algorithm from the American Heart Association, which shows that if the patient have a mechanical EF normal, and the patient have a symptom, we treat the patient with the medication, and if the symptomatic PVC still persistent, we could do the ablation or another treatment. So here is a comparison of the treatment of patient with idiopathic PVC compared between the ESC guideline or the AHA guideline. You could see that in the patient with RVRT, particular PVC, and normal LV function, the treatment is medication. Then if the patient have a PVC with more than 20%, but asymptomatic and normal LV function, the catheter ablation will have an indication of 2B, and the medication have no indication. So here is some summary of the common medication for the treatment of PVC. The first is amiodarone. The effect on EKG is decrease the standard note frequency and prolong the QT interval. Indication for the PVC, VTF, and VF. And another common medication is a beta blocker. It could decrease the standard note frequency, prolong the PI interval, and shorten QT interval. Another kind of beta blocker is nadolone or propranolone, is the same effect of the beta blocker. And in some patients, we could use the verapamil for the treatment of the PVC, and especially have the indication in the left ventricular tachycardia. And another medication is flicain or pregabalin. So there was something we need to focus before we use the medication for anti-arrhythmia. For example, in the patient requiring the sodium channel blocking agent, such as the class 1 medication, we need to assess the patient risk profile before initiating. And if patient have a no cardiac disease or ECG abnormality or abnormal electrocardiogram, if patient have a this abnormal, we need to check for the contraindication, that Purkinje syndrome, prior myocardial infarction, or severe LV dysfunction, or we need to check the precaution, such as LV hypertrophy or some kind of AV block or prolonged QT interval. And if patient don't have any abnormal, we could initiate the treatment and assess after 1 or 2 weeks. If have a change on the QRS or abnormal of exercise test, we need to change different medication or reduce the dose. And if the patient could tolerate the treatment, we could continue the treatment. And another caution is a patient require a drug with associated with QT prolongation, such as amiodarone. We also need to assess the patient risk profile, and if the patient have a long QT, it is a contraindication of the kind of medication. And if the patient have the hypokalemia, hypomagnesium, renal failure, or LV hypertrophy, or heart failure, we could start the medication. And we should follow up the patient after 1 or 2 weeks of medication and or increase the dose. And if the patient have a QTc more than 500 milliseconds, we consider to change to different medication. And if the QTc within the normal range, we continue the treatment. Another kind of treatment for the PVC includes the lifestyle change, including stop smoking or reduce the caffeine intake. Need to manipulate some risk factors such as hypertension or the OSA syndrome, administration of potassium and magnesium, and the anti-fatty acid and lipid may stabilize the membrane and could maintain an electrocardiogram. However, some acidity show that they will affect of the kind of treatment. For the device treatment of PVC with normal without the superior heart disease, the role of ICD in the patient population is limited. And for the catheter ablation, in the recommendation of SC or the 8A, we could see that the catheter ablation have the first line treatment for patients with symptomatic and normal LV function or LV dysfunction. Is that have the 2B class indication in the PVC burden more than 30% asymptomatic and normal LV function. And this is a recommendation for catheter ablation in PVC with patient with or without LV dysfunction. It means that catheter ablation could be indicated in patients with monomorphic PVC and who the medication are effective or not tolerated or not preferred for long-term therapy. And it could have a 2B indication in the patient with VF and refractory for with medication. So here is some representative study about the catheter ablation. The first is a multi-center outcome for catheter ablation of idiopathic premature complex. You could see that the effect of ablation success is higher in the RVLT location of PVC or in the TAP. And this kind of procedure have a safety, which means that very low complication. With the more commonly complication in major chronic complications such as neuroaneurysm, hematoma, or AV fistula, and another complication is tamponade with 0.8%. And another study which compares the medication of treatment of PVC and catheter ablation, we saw the result that in the patient with catheter ablation have a better outcome compared to the group with medication. However, in 2023, there were a meta-analysis compare the anti-arrhythmic drug medication and the catheter ablation. We saw that the catheter ablation associated with the reduction in the PVC recurrent, the PVC burden, and increase the LVAF. And the complication also lower than the group with medication. However, the study have a limitation that for purpose study include only the patient with IV or PVC, and they did in the electroanatomic mapping and no use eye or contact force, and no data for the quantity of the apply or symptom or cause. And in the future, the result of Ethiopia or pilot or CAT PVC will help us to have more insight when compare the treatment of PVC with medication or the catheter ablation. So this slide shows the overview of the main difference in the recommendation and news aspect from on the guideline, recently guideline, and they focus on that the catheter ablation could be the first line therapy in idiopathic RVOT and vascular PVC or VT, and the preferred therapy in the coronary artery disease patient with chronic artery and recurrent VA. And it also add some novel aspect with that new session on the electrical storm and the comprehensive supplement data. So through my presentation, I want to remind us some take-home message, including the first is the PVC is quite common even in the normal people, and the diagnostic of PVC includes assessment for underlying structural heart disease and quantification of total PVC burden. And the PVC at more than 20% or have a high rate of tachycardia-related cardiomyopathy may require treatment. And the treatment involves medical treatment with beta blocker, calcium channel, or another anti-arrhythmic medication, and catheter ablation in selected cases. And catheter ablation show good outcome in patients with RVOT or vascular PVC and PVC cardiomyopathy. Thank you for your kind attention.
Thank you, Dr. Hong, for your excellent talk. Because of time schedule, we only can accept one question, short question from the audience. Any question from the audience? Yeah, maybe I can ask one question. So how long will you record to determine the burden of BPC? Usually in Taiwan, we use only 24-hour Holter. But I think that's not sufficient. Yeah.
So, you know, in my hospital, we are usually use a 24-hour Holter EKG to assess the PVC burden. Because
of insurance.
The insurance, and we don't have, you know, enough the new device.
Yeah, I think same question from Taiwan also. Okay, thank you, Dr. Hong, for your excellent talk. So because of time schedule, let's move to the next section. Dr. Doni Yugo Hermanto from Indonesia. Today's topic is arrhythmogenic mitral valve prolapse in unexplained cardiac arrest. Dr. Hermanto, please.
Okay, hello, good morning. Good morning, all of the participants and chairpersons. Thank you for the invitation. I would like to share my slide. So today I want to talk about the arrhythmia in mitral valve prolapse. So This is arrhythmogenic mitral valve prolapse in an unexplained cardiac arrest, and we should see the predisposing factors for this kind of symptoms. Okay, so as an introduction, MVP is the most common valvular heart disease that affecting about 2 or 3% in general population, and it's well characterized by echocardiography. And the outcome of the MVP is usually benign, especially in the absence of mitral regurgitation. And the link between MVP and sudden cardiac death is reported is quite low, it's around less than 1% in unselected individuals with MVP. However, in the autopsy, the prevalence of MVP among young adults, young patients with sudden cardiac death is reported is around 4 to 7%. So this is the definition of MVP as the echo shows. Usually we use the echo. So MVP is defined as the systolic displacement of one or both mitral leaflets more than 2 millimeters above the plane of the mitral annulus in the sagittal view. And we usually divide the MVP into two distinct diseases. The first is the myxomatous MVP or Barlow disease, where there's a very excessive fibroelastic tissue around the mitral valve. And there's also the second one is the fibroelastic deficiency, where the mitral valve mass is not redundant or excessive like in the Barlow's disease. And then there's another term of mitral annular disjunction. So it's some kind of MVP, but the systolic separation, it happened not only in the valve, not only the billowing of the valve, but also related to the ventricular myocardium. So there's systolic separation between the ventricular myocardium and the mitral annulus. In the only MVP, there's no separation between the ventricular myocardium and the mitral annulus. And especially it happened in the supporting the posterior leaflet or the PML. And amongst patients with MVP, the prevalence of MAD is around 20 to 58%. So this is the difference between mitral valve prolapse and the MVP plus MAD. So in mitral valve prolapse, the annulus is stay the same, so there's no separation between the annulus and the ventricular myocardium. But in the right side figure, we can see that during the systole, there's a separation between the ventricular myocardium. There's a gap to the mitral annulus. That's what we define as MAD or mitral annular displacement. So this is the echocardiographic images. Between this one is the normal valve without any MVP. The upper right is the myxomatous bileaflet MVP, but no MAD. So the mitral annulus is still attached to the ventricular myocardium, and we can see there's the billowing of more than 2 millimeters in both of the valves. So this bileaflet MVP. And then in the lower left, there's a myxomatous MVP. There's a very excessive tissue there in the PML, especially, and there's MAD. So there's separation between the mitral annulus and the ventricular myocardium. And the lower right is the myxomatous MVP as well, with the MAD of 12 millimeter of length. So the mitral valve prolapse usually sometimes is correlated with arrhythmia. So the mitral valve prolapse with arrhythmia, we call it arrhythmic mitral valve. And the definition of the arrhythmic mitral valve or arrhythmic MVP is the presence of MVP with or without mitral annular disjunction, and then it has to be the presence of ventricular arrhythmia. It could be a frequent one. There is more than 5% of total PVC burden, or a complex one, the non-sustained VT or VT, or there's evidence of VF. And the important one is the absence of any other well-defined arrhythmic substrate, such as the scar-related VT and ischemic heart disease and so forth. So what about the MVP, MR, and the risk of sudden death? So this is the study from Grigioni et al. In 1999 in 348 patients with mitral regurgitation due to MVP. And we can see that the incidence of sudden death in around 10 years of diagnosis is quite common, is around 19% plus minus 4% in the incidence of the sudden death, and the total in cardiac mortality also quite high in 10 years after diagnosis is around 43%. And what about the predictors of sudden death in patient with mitral regurgitation and with because of MVP? The predictors is the first is the ejection fraction with the risk ratio of still around 6%, and then the NIHA functional class also have the predictor of the sudden death. The presence of AFib is not the predictor of sudden death in patient with MR due to MVP. So what is caused the arrhythmic events in patient with MVP? First, in patient with MVP or MAD, there's a systolic curling of the basolateral segment of the heart. So it could cause the basolateral hypertrophy, and in the end, it causing the strain pattern to be dysfunctional. Also, the difference in myocardial work index. There's also mechanical dispersion between the myocardial in the left ventricle, and post-systolic shortening also different in normal subjects. So it creates a fibrotic changes that was detected, that can be detected using the CMR of the using the LGE. There's a fibrosis there, and the fibrotic changes also between the mitral apparatus and the surrounding myocardial cells and papillary muscle that can cause a ventricular arrhythmia. It will cause also because of the stretch activated EAD or early after depolarization, causing a PVC, and sometimes it could lead to repolarization changes that will cause an T-wave inversion in some of the inferolateral leads usually, and it will cause ventricular arrhythmia from VPC to the devastated ventricular tachycardia and ventricular fibrillation. That's the pathomechanism. So it's mainly due to fibrosis because of the stretching of the papillary muscle and the myocardial apparatus near the valve. So this is the predictors of the ventricular arrhythmia in patient with MVP. First is the we could talk about the phenotype. So actually the MVP could be with mitral regurgitation or MVP without mitral regurgitation. So actually the overall survival of subject with MVP without severe MR or LV dysfunction is actually equivalent to the general population. But in patient with severe degenerative mitral regurgitation, that's the patient with MVP with severe MR, irrespective of the valvular morphology, is also at risk for ventricular arrhythmia. So if there's MR, if it's severe, or there's LV dysfunction, regardless of there's an MAD or the prolapse of the B-leaflets or so forth, there's this is significant risk for ventricular arrhythmia. And then the other one is severe myxomatous MVP, independent of MR severity. So in this kind of patient or this kind of subset phenotype, there's no apparent mitral regurgitation, but the morphology indicates a high risk. What kind of morphology is high risk? Usually, if there's a myxomatous degeneration with marked leaflet redundancy, excess leaflet length, and thickness, but not always have a B-leaflet MVP, but usually have a B-leaflet MVP. So there's another factor is the clinical risk factor. Usually, the arrhythmic MVP is usually affecting the female and young adults. Also, they pose risk. And then the ECG. ECG, we also have to see the ECG, whether there's a high risk feature of the patient in the patient with MVP. So this is some kind of high risk feature that can be found in the patient with arrhythmic MVP, we can find there's a T-wave inversion or QT prolongation, fragmented QRS. The fragmented QRS usually due to the abundance of scar at the LV or PVCs. And T-wave inversion also related, and QT prolongation as well is also related with the repolarization abnormalities in patient with MVP. And in Holter, usually we can find also found the ventricular arrhythmia, and the grading of the ventricular arrhythmia we'll talk later. So it's also important that we also see the morphology of the PVC. So if the PVC, if the morphology is near from the mitral valve annulus or the mitral annulus, then it could be suggestive that the ventricular arrhythmia is related to the MVP. But if the morphology of the PVC is more likely to be outflow tract, like inferior axis and so forth, then it would likely not related to the MVP. So this is the more ECG morphology of the VA that is related to the MVP. So all the VPC or ventricular arrhythmia that is coming from posterior papillary muscle, anterior papillary muscle, anterior mitral annulus or posterior mitral annulus is related to the presence of the MVP in this patient. So this poses another risk for the patient to have the arrhythmic MVP. And then we can also divide the patient with MVP according to the frequency of and the type of the ventricular arrhythmia. So we can divide the patient have the mild ventricular arrhythmia in patient with MVP if the PVC is more than 5% and or the VT rate or the VT speed is less than 100 beats per minute. We can also classify the patient into moderate if the VT, if we found a VT during the monitoring with the rate of 120 to 179 beats per minute, and we call it severe ventricular arrhythmia if we found the VT have a rate of more than 180 beats per minute and or there's a previous ICD implanted in those patients. So this is the paper from SIAC. There's the MVP patient, 595 patient, and they got a 24-hour Holter, and they divide between no arrhythmia, mild, moderate, and severe arrhythmia. And we can see here the Kaplan-Meier of the mortality rate. We can see in follow-up around 8 years, the mortality rate in patient with severe arrhythmia is somewhat doubled than compared to the patient with no or trivial arrhythmia. And also we can find the incidence of death, ICD implantation, and VT ablation is higher in severe arrhythmia and mild to moderate arrhythmia compared to patient with no arrhythmia. And this is the MVP characteristic of the severity group. And the determinants of ventricular arrhythmia severity, actually, there's the presence of mitral annular disjunction, there's the redundant leaflets, or there is a T-wave inversion or ST segment depression in the 12-lead ECG. There's the predictor or determinant of the ventricular arrhythmia severity. But we have to also do Holter monitoring at least 24 hours in all patients with MVP to analyze whether there's a ventricular arrhythmia or not. So this is the echocardiographic predictors of ventricular arrhythmia. So the morphological predictors of the ventricular arrhythmia, usually there's an MAD, or there's a severe myxomatous degeneration by a very thick and redundant leaflet, usually compromising multi-segment of the bileaflet mitral valve. There's a mitral annulus dilatation, also the bad predictors, lower GLS and lower EF, also the bad predictors for the ventricular arrhythmia in patient with MVP. And this is also the predictor of ventricular arrhythmia according to the CMR. If there's a diffuse LV fibrosis determined by the T1 mapping, is associated with the increased risk of complex ventricular arrhythmia with patient with MVP. And if we have a patient with MVP, but there's a poor echo window, there's not clear whether there's MAD or not in this kind of patient, we can do CMR assessment as well. So this is the CMR image for a patient with MVP. This the upper left is the patient with MVP with moderate MR but without MAD, and in the right upper there's a we can see there's a MAD here, the separation between the leaflet and the annulus and the mitral and the ventricular myocardium. And in the lower left and in the lower right, there's also we can see in the LGE there's a fibrosis there around the papillary muscle and the basal segment near the mitral annulus. So as the summary of the risk factor of sudden cardiac death, we can see in the resting electro ECG findings, T-wave inversion, Q2 prolongation, sometimes QT dispersion, the presence of VPC that originating from the papillary muscle, or the presence of non-sustained or sustained VT. The clinical factors such as young female, palpitation, syncope and presyncope, of course, there's a risk factor of sudden cardiac death. Also, imaging findings using the echo and the MRI could determine whether the patient have a high risk for sudden cardiac death. The biomarker actually it's not that well defined. The valuable biomarkers still not have an impact in predicting the SCD or ventricular arrhythmia in patient with MVP. So what about the management? I use from the EHRA expert consensus. So in patient with MVP, we should divide it between the patient with asymptomatic, only patient with palpitation, patient with unexplained syncope or presyncope, or patient with aborted cardiac arrest. If patient with aborted cardiac arrest, then the patient should go directly to the ICD implantation. And for the asymptomatic patient, we always have to consider putting the Holter in the patient to see whether there's a episode of ventricular arrhythmia or not. And that's also the case for a patient with palpitation or unexplained syncope. We use the Holter and then we divine if there's a VT or no VT. If there's a patient VT and the VT is high risk, so we can consider the presence, the implantation of ICD, and we also have to see whether the MR is severe or not. And we also have to consider or do the mitral repair if the MR is severe. But if the patient have VT but the high risk criteria is not met, we can use ILR, and then we can just do the frequent monitoring. And if the patient have the high risk feature of or the ventricular arrhythmia during the monitoring, we can propose for the ICD implantation. Okay, so as the conclusion, MVB, though it's often benign, but it can predispose to serious arrhythmia and sudden cardiac arrest, especially when arrhythmogenic features are present. And Holter monitoring is quite valuable in all patients with MVP, regardless of symptoms. So every patient with MVP, we should consider putting an Holter in. And imaging studies should evaluate the presence of MAD and other high-risk features such as the bileaflet MVP. And ICD also indicated as secondary prevention. But in primary prevention, measures should commence to the heart failure guideline. So if they also already heart failure, EF less than 35 and the NIHA functional classes more than 1-2, we can consider ICD as a primary prevention. Okay, thank you. I think that's all my talk for today. Okay, thank you.
Thank you, Dr. Mendo, for your inspiring talk. Any question from the audience?
I actually have a question.
Yeah, please.
Now, do you really do Holter monitor on every patient who has mitral prolapse? It seems undoable in Thailand.
Yeah, actually, it's whether the patient goes to the EP guys or the AO guys. If the patient goes to the EP guys, we will do Holter. But if the patient just went to the echo guys, I think not all. Only the symptomatic one that that will send to the Holter. But if the patient goes to the EP, MVP goes straight to the Holter. Yeah.
From the consensus, it looks like everyone who gets off the table from an echo, if they have mitral prolapse, should go home with a Holter.
Yes,
that's a lot
yes,
of,
yes.
That's a lot of cases.
Yes, there's a lot of cases actually.
Mm-hmm. Yeah, it seems not feasible in many countries.
Yeah.
Do you do that in Taiwan, Dr. Lin?
No, yeah, actually, if the patient have an EP and have the symptoms such as a palpitation, or you incidentally found a PVC, we will arrange a Holter, but not in every case. Yeah, I think that's in Taiwan situation. Also, I have a question. How about the role of electrophysiology study? If you induce ventricular arrhythmia in the EP lab, will you what is the role of the EP study in this patient population?
Yeah, so there's a paper from I forgot the author of the paper. So the paper is in patient with MVP and aborted sudden cardiac death, or patient with MVP plus documented VT or VF, and they do the EP study on that kind of patient, and the result is 50% of those patients is actually not eligible. So that's the problem. So if we do could not induce PT in those kind of patients, so they're still debatable whether the patient have actually risk of ventricular arrhythmia or not. In era consensus, the implementation of ILR is more recommended, but actually the ILR is actually not that easy to implement, because usually the patient is just won't get the device just stuck in their body for like 3 years. So maybe in some of cases it's our discretion to do the EP study, although we have to aware that the sensitivity and the specificity is actually not that good.
Okay, thank you. I think you have the same experience, yeah, in EP study in this patient population. Any further question? Okay, if there is no further question, thank you, Dr. Mento, for your inspiring talk. Yeah,
Thank you.
And we will move to the next speaker, Dr. Nirubong Mathachitiphan from Thailand. Her talk is catheter ablation or anti-arrhythmic drug in post-infarct ischemic cardiomyopathy, rethinking viral Vanish and Vanish 2. Doctor, please. I can hear your voice.
Okay.
Okay.
So today I'm gonna be talking about the VT ablation and catheter ablation of or antiarrhythmic medication in post-infarct cardiomyopathy. Rethinking via Vanish and Vanish 2. And first, I want to briefly review the usual clinical cause of ischemic VT and how we can intervene as cardiologists or electrophysiologists. So first, of the events, we'll start with cardiac injury or ischemia, and then the heart will start remodeling, and then after that you'll start to get VT episodes, and recurrent VT will occur down the line without any treatment, and then at the end of the course, there will be VT storms, ICD shock, and then heart failure or arrhythmic death. So what we can do as cardiologists first before having ischemia is CV prevention. And then if the ischemia already occurred, we need to give them optimal medical therapy. And then if they meet criteria for AICD, then we'll give them AICD. And then after several years, they'll start to have VT episodes. I mean, some of them will start to have VT episodes, and then they'll get ICD shock, and then we can start the antiarrhythmic drug. And then if they have recurrent VT, then more antiarrhythmic drug and or VT ablation. Of course, this is what we usually do in the past. So we will wait for the recurrent VT, and then we do VT ablation. And or if they have VT storm, then VT ablation is going to be having roles here. But you have to keep in mind that you don't want to let your patients have ICD shock too much because it's not of course, ICD shock will save lives, but it may cause anxiety, depression, PTSD, and they are associated with increased mortality and worsening heart failure. And an answer question in the EP world is when is the most optimal timing for ablation for ischemic VT to prevent a lot of shocks in our patient and or to improve heart failure, hospitalization from recurrent VT. Should we do VT ablation earlier before antiarrhythmic drug or even VT ablation at the time of AICD implantation? Before going further into detail, I want to give some general idea about why we are talking about mostly when we talk about VT ablation, we mostly talk about ischemic VT ablation, but and not non-ischemic ones. As you can see here in this MRI, panel B is the post-MI scar from ischemia, and you can see that the scar from ischemia is going to be mostly endocardial and quite well-defined border because it's caused by territory of coronary arteries, and the VT ablation will be more effective in ischemic cardiomyopathy other than comparing to the other non-ischemic ones because of these reasons. So mostly when you read the VT ablation trials, will mostly include the ischemic patients. And what exactly is ablation? Just to give some idea for non-EP people, we'll all go in with a 3D mapping system, and then we will map out the scar. And nowadays we mostly do the substrate modification as a majority of the ablation. The pink here is the normal tissue, red is abnormal tissue with a low voltage, and the scar area is the area that is not pink. And VT ablation is an invasive procedure. At some point, sometimes we need to use hemodynamic support like ECMO in this picture on the right. So it's a risky procedure. How does it help? This is the questions that has been long asked. So does it decrease VT burden? Of course, it should. Decrease ICD shock? Yes, we know that it can decrease ICD shock, but does it decrease heart failure hospitalization? Does it improve quality of life? Or does it improve mortality? And that's why we need multiple RCTs to answer these questions. So here is a timeline of different VT ablation trials, the major ones that has been out. As you can see, the first in the early days of ablation, about 20 years ago, SMASH VT and BTAC. It took 3 to 4 years for a good big VT ablation trials to come out. But suddenly in 2022 and from 2022 until now, many newer VT ablation trials came out, and many of them has significant results, including VANISH and VANISH 2 that we are going to talk today. And before going deeper into the trials, we need to keep in mind that there are heterogeneities of the RCTs in of VT ablations. There's no single trial that can be generalized to all your VT patients. So you need to look into detail. And one of the most important factor that is going to be discussed today is that different VT ablation trials have different timing in VT clinical course. I'll show you in the next slide. And to put in an easier way is the clinical question that is being asked is when is the most optimal timing for ischemic VT ablation so that the patients can get the most benefit from the procedure, because it's a risky procedure. When should you put the patient with their upfront risk during ablation, and so that they can get the most benefit out of it. So to help visualize timing of ablation in reference to VT clinical course, this is the clinical VT clinical course and the timing of ablation in each separate trials. So as you can see, the earlier trials like SMASH VT, which came out in 2007, VTAC 2010, they did the ablation quite early at the ICD implant or around the ICD implant timing, and then later trials did the ablation at different time point of clinical course, and also post-SCD and preventive VT, and Berlin also did the early ablation prophylactically, but with more specific patient population, more selective with the patient inclusion criteria. So the primary outcome of the early RCTs before 2022 are like this. So mostly they are positive. They are positive. It's trending the same way in helping reducing the appropriate ICD shock and freedom from VTVF. In other words, it reduced VT burden in comparing to antiarrhythmic medication. The green shadow trials are from the primary prevention ablation, prophylactic ablation earlier in the course. And then later on, Vanish in 2016, they did the ablation in the drug refractory VT patients who already have ICD implanted. And Partita, another famous trial, did the ablation after first ICD shock, and then Survive VT in 2022 did ablation after an ICD shock, comparing with amiodarone. As you can see, most of the trial VT ablation improve, reduce the burden of VT. But more significant question in cardiology is that if any given procedure reduce the mortality. Unfortunately, in VT ablation trials, mortality is mostly not significant as a single endpoint. There are mortalities that are included in composite endpoints in the trials, like Vanish or Berlin or Partita or Survive VT. But as a single endpoint, there's no trial except for Partita that has a positive mortality benefit. And why is that? Because most of the trial is what we call prophylactic VT ablation, meaning ablation quite early in the clinical course, like SMASH VT, VTAC, SMS, Berlin, and preventive VT. So in the prophylactic VT ablation, it does decrease VT burden, decrease VT recurrence comparing to non-ablated arm. But it has failed to improve clinical benefit on overall heart failure related outcome and mortalities. And why is that? Because many patients who got ICD, only about less than 50% will get the real ICD shock or have sustained VT in the future. And however, if we there might be possible indication to specific high-risk subset of patients in this group, like preventive VT trial that brought patient with the CTO, that is non-fixable lesion, and do a VT ablation at the ICD implant. And the result came back pretty good. So later trials, Vanish 2 and Partita trials will be ablation later in the course. And let's see the trials that is in the headline today, Vanish and Vanish 2. Vanish trial. So they included patients with prior MI and with ICD in place, and VT event in the preceding 6 months, and the qualified VT events are as follow. A bit too much, but yes. And they have to fail first-line antiarrhythmic therapy, class 1 or class 3, and failure are defined as follow. And the patients were randomized 1-to-1 into VT ablation arm or escalated antiarrhythmic therapy. And where exactly was the Vanish trial in the clinical spectrum of the ischemic VT? It's almost at the end of the spectrum. So pretty sick patients in the Vanish trial. And they were randomized to ablation or increased antiarrhythmic medication. So these patients are already on antiarrhythmic medication before randomizing to ablation or increased antiarrhythmic medication. And here is the result. The primary endpoint is the composite endpoint of death, VT storm, and appropriate ICD shocks. Oops, sorry. As you can see, the composite endpoint, the primary endpoint, is positive. It's mostly driven by reduction of the VT storm. Death and appropriate ICD shock, especially death, was not significant. And then came Vanish 2 last year. The patient population, they included prior MI as previous Vanish, and they all have ICD in place as previous Vanish. And then VT event in the preceding 6 months, and the clinical the definition of VT event is similar to the previous Vanish, but they the patients were not on antiarrhythmic medication. And the patients were randomized into 1-to-1 into VT ablation or antiarrhythmic medication. It could be amiodarone or sotalol. So Vanish was here near the end of the spectrum, but Vanish 2 tend to ablate in the earlier stage of VT clinical course. So patients are not on antiarrhythmic yet, but already have ICD here. And ablate, they were randomized into ablation versus initiate ICD, antiarrhythmic medication. So this is the result of Vanish 2. Primary endpoint came back also positive again. The primary endpoint are composite of death, VT storm, appropriate ICD shock, and sustained VT below the detection of detection limit of the ICD. So primary endpoint came back positive, but it's mostly driven by appropriate ICD shock after 14 days. and treated sustained VT below detection limit. And when we look further into the detail of antiarrhythmic that is used in VANISH2, patients who got sotalol were they have a pre-specified criteria for patients who in the antiarrhythmic arm. If the patient is less sick, like these are the criteria for sotalol, they will receive sotalol. Otherwise, if they are sicker than this, then they will get amiodarone. So for patients who got sotalol, they have to have GFR at least 30, NYHA class 1 to 2. Sorry, I missed here. LVEF at least 20% and not a VT storm. If the patients does not meet criteria to get sotalol, they will all get amiodarone. So you can tell amiodarone patients, the group of patients who got amiodarone are sicker. And the magnitude of primary endpoint reduction is higher in sotalol eligible patient. So overall, patients who are less sick have a better outcome from ablation. So question is why most trials except Partita not show mortality benefits, because the small number of the patients included, so they are underpowered for mortality. And VT patients are sick. There are many other competing risks for death in both ablation and control groups. Timing of ablation in the course, the earlier days, ablation may be too early or too late, and all patient selection might not be optimal yet. And also different ablation protocols and endpoints are used in multiple centers. And in all the trials that I have mentioned, every patient already got ICD in place, which already significantly reduced mortality. So it's difficult to add on the benefit of that on top of the ICD. To put it easier to make it easier to look. So to make the point of the previous slides, maybe ablation in all patients who had ICD implant does not show mortality because they are too healthy, or when we do ablation when they already have VT storm, they may be too sick for that. So the good area, the good timing for VT ablation might be in this area when they got AICD treatment and or before ablation. And timing of when we look at the most recent guidelines in 2022 for VT ablation in ischemic patients, ablation at ICD implant was a class 2B indication, and VT, despite antiarrhythmic medication, if they are taking amiodarone, is class 1 indication, and if they are already taking beta blocker or sotalol, is class 2A indication to do VT ablation. And unfortunately, the most recent guideline was in 2022. It was ESC guidelines, and the trials since 2022, there are many significant trials that came out, and it was positive. And the timing of those newer trials are in this area. So maybe next guidelines, the timing of VT ablation might be in this area after ICD implant and before antiarrhythmic initiation. So take home message from this talk, VT ablation has shown to reduce VT burden for sure, but other things like heart failure, worsening heart failure hospitalization, or mortality may need larger trials. And for most recent trials, best timing for ablation may be after the first ICD therapy, ATP or or ICD shock, regardless of antiarrhythmic medication, especially in patients who might not be appropriate for antiarrhythmic, and or patients who are less sick, like patients who were eligible for sotalol in the VANISH-2 trials. I guess that's it.
Thank you, Dr. Newbon, for your inspiring talk. I enjoy a lot. Any question from the audience? I think you point out a very important point that when reviewing the trial, the timing of intervention is also very important. Yeah, so I think most of the doctors choose late ablation strategy. Am I right?
Yes.
How about in Thailand?
Yeah, I'm the late guy.
I'm the late guy.
Nilubon might do it earlier, but I guess I actually have a question again. So when would you do a case on hemodynamic support? Which one would you pick?
Yeah, when the hemodynamic is not stable, which hemodynamic support will you choose?
Right. Those are usually they usually come with the patient. But Dr. Nilubon, is there any particular case you would actually choose to electively put on, let's say, ECMO before ablation?
So there's this pain ESD score, that is a scoring system to predict how likely the patients are gonna crash during the procedure. So that is by the book. It also depends on your hospital, which hospital is it's safe to do hemodynamic support. But if you want to have a criteria, so the pain ESD score is helpful. But these days, even with patients with high pain ESD score, we will do just have the access ready for ECMO, and have the team ready for ECMO, but we don't put the ECMO on patient prophylactically before the ablation.
Yeah, I usually don't use hemodynamic support. I ablate after the hemodynamic support has already been put on patients. I won't use prophylaxis because in my situation. Yeah. How about Dr. Takapong? Will you prophylaxis use ECMO or LVAD?
No, I usually think if they have to be on hemodynamic support, they're probably too sick.
Yes, I agree with you.
Hey, Dr. Omar has a question. Dr. Nilubon, he's asking, is there any role of MRI, cardiac MRI, to pick which patient you want to be doing ablation or not?
Yes, in a non-ischemic patient, then yes, to visualize how extensive is the scar. But in ischemic patient, we kind of know. I mean, if you are sure that it's truly ischemic, you kind of know where the scar should be, even from the echocardiogram. Yeah, so yes, for MRI is helpful for non-ischemic patient to help you visualize. If there are too many patchy scars, then that might be not a good candidate for ablation.
Can I just elaborate a little bit more on the question, if you would allow me, Mr. Chairman? Like we know from now that we wait until the event happens, and then we actually interfere. Do you think CMR will have a value on, predicting, oh, this patient, I should put him on my list even before an event happens?
That would be, that's my question, right? that would be more like a prophylactic ablation, right? Or before the VT happens. Yes, I would think so. It also depends on the cost of the MRI and how easy you can get those MRI. If it's very accessible, then that's a good idea. For ischemic, you mean for ischemic patient or non-ischemic patients?
Yeah, for ischemic patients, yeah. Because you know, when they have like an extensive scar, it's just a matter of time that they will come with VT. So should we do it, you know, before actually the VT happens? I think we need maybe another trial. Please, yeah.
MRI guided prophylactic ablation. Yes.
I think that maybe MRI has some predictability, but it's hard to use in decision making. You can put ICD in every patient with delay enhancement on MRI. Even some study prove that it has its predictability, but it's hard to use. That's my opinion. Yeah. Any further question?
My thought on that is actually, you know, usually these patients with bad EF on ICD are usually sick. If we do a case and we have a complication, it usually turn out quite bad. So that's why I wait rather than going in early.
Yeah, we do no harm. Yeah. Okay. If there is no question, this thanks Dr. Nimubong for her inspiring talk. And Dr. Tachapong will chair the next three speakers.
Okay, all right, great. Thank you. Next will be Dr. Yuki Komatsu from Japan, Tsukuba, the capital of Purkinje VT.
Hi.
So he'll be talking about emergency intervention in Purkinje triggered VTVF. Dr. Komatsu, please.
Yes, thank you. It's a privilege to speak at APSC webinar today. Okay. My talk is about the interventional therapy that is catheter ablation in Purkinje fiber or vascular substrate triggered ventricular fibrillation. Who, when, and how. The catheter ablation, as you all know, is a potentially effective treatment strategy for electrical storm due to ventricular fibrillation as a bailout strategy. By the way, the definition of the electrical storm is like 3 or more episodes of VT or VF occurring within 1 day, requiring either antitachycardia pacing or DC. So multiple therapies and modalities are needed to manage the electrical storm. First of all, a patient with electrical storm should be managed in the intensive care unit. And medical therapies include revascularization if there is a coronary stenosis. Of course, antiarrhythmic drugs, including beta blockers or amiodarone, and so on, and also the deep sedation with sometimes, often with mechanical ventilator, MCS or overdrive pacing, and also autonomic modulation is also important. But interventional therapy, catheter ablation, is one of the important therapeutic options. So the question is, who is eligible for ablation therapy? The indication for catheter ablation is the patient with multiple episodes of ventricular fibrillation, electrical storm, requiring multiple shocks, which is refractory to the medical therapies. And the more importantly, as you can see, this monitor, same monomorphic PVC was frequently observed, and it initiated ventricular fibrillation. So this kind of frequent monomorphic PVC triggering VF is the good candidate for the catheter ablation because the ablation target is the trigger PVC. So therefore, it is very important to identify the 12-lead EKG morphology of the PVC triggering ventricular fibrillation as much as possible. In Japan, we have it's available the 12-lead Holter monitoring. So if the patient is in the electrical storm, we put the 12-lead ECG Holter monitoring one day, and then we will get the 12-lead morphology. And then the target, we don't know. The first guy is the bad one, or second guy is what bad one. We don't know that. But often we have the similar type of the first beat trigger PVC, just initiating the ventricular fibrillation. That is the target of the ablation. So the indication of the ablation of idiopathic VF is just targeting the ablation targeting the PVC, because there is no arrhythmogenic substrate in these idiopathic patients. So therefore, the patient with frequent monomorphic PVCs, in particular refractory to the medications, may be the candidate for the ablation. So I mainly today talk about the ischemic VF. The ablation of ischemic VF is it was back in 2004. There are several case series reports describing the ablation of the ischemic VF and then targeted by the Purkinje triggers. These PVCs were thought to originate from the Purkinje fibers within the skull border zone. And as you can see, during sinus rhythm, there is a Purkinje potential. This is a very sharper signal compared to the ventricular potentials. And then Purkinje potential is preceding the trigger PVC, very earliest potential. That is the target. So we conducted international multi-center study to investigate the short and long-term outcomes of catheter ablation of the treatment of VF storm refractory to medical therapies in patients with myocardial infarction. These are the contributing centers, including Japanese centers and Bordeaux, France, and also mainly from the Japanese centers. So this study was published in 2019. This study retrospectively evaluated 110 patients, myocardial infarction, then suffering from the ventricular storm, and all of them underwent the ablation. And the VF storm was refractory to these medications, including the antiarrhythmic drugs and overdrive pacing or ventilator. The time from VF to ablation was median 4 days. So this is the most common type of the Purkinje trigger, originating from the skull border zone. As you can see, the upper panel, you have the voltage map. The red color is the dense, and the green color or yellow is showing the skull border zone, and purple is the normal voltage. And then here we got the very nice Purkinje potential during sinus rhythm, and then this blue star is the triggering PVC, and then you can see the Purkinje potential is preceding the trigger PVC. That is the focal source of the trigger PVC, and that is the target. And then in our study, 80% of the patients have the trigger originating from the skull border zone of the left ventricular septum. But some patients have the triggers in the multiple sites in the dense skull. It's very injured scar, huge scar in the anterior and the septum. This is a very challenging case, but even in this kind of case, we identified the Purkinje potential, which is associated with the VF initiation. And then this slide shows the site of origin of the trigger PVC. As you can see here, more than 70% of the trigger originated from the left ventricular septum. And then this is the result of ablation. Elimination of triggering PVC was achieved in 91% of patients. Interestingly, among patients who underwent inducible induction test at the end of the procedure, 81% of them obtained non-inducibility of the ventricular fibrillation. These are the complications. The ablation strategy at that time, 2019, target the triggers originating from the Purkinje fibers, which result in the damage to the conduction system in about 10% of patients. I would like to discuss the ablation strategy later. So this is the acute results of ablation. During 30-day follow-ups after ablation, VF suppressed in 84% of patients. However, despite ablation, VF storm was not suppressed in the remaining 16%. This is the Kaplan-Meier curve of recurrence for VF or VT and the electrical storm after ablation. The left side of the figure is indicating the 30 days follow-up, and the main part of the figure indicates the long-term follow-up over median follow-up duration is about 4 years. And only one patient developed recurrent of the electrical storm during the long-term follow-up, which means that the once patients survived the electrical storm at the acute phase, the recurrence of the electrical storm during long-term follow-up is quite rare, while the isolated episode of the VT, not the VF, was documented in 9 patients. How about the mortality? We're really interested in the mortality, and then this slide shows the in-hospital survival outcome in the 18 patients with uncontrollable VF storm in the acute phase. This is as expected. Uncontrollable VF storm was strongly associated with the subsequent in-hospital death. Odds ratio is 11.47. And then on the other hand, in 92 patients in whom VF storm was subsided, and then 24% of them developed single episode of recurrent VF or VT, which is not the electrical storm, just a single episode of the recurrence of VF or VT. And then of these, the second ablation was done in 12 patients, and then the other 12 patients had the management of the antiarrhythmic drugs. Importantly, the incidence of the single isolated episode of the recurrent VF or VT was not associated with the in-hospital death. This suggests that the good indication of the ablation may be the electrical storm rather than the single episode of the VF. Black line, this is a short and long-term mortality. The black line is the all-cause mortality, and blue line is the cardiovascular mortality. Green line is non-cardiovascular mortality. As you can see, in-hospital death occurred in 27% of the patients, mainly due to the cardiovascular disease. Cardiovascular reason. So, and then what about the long-term follow-up? The 30% of the patients died with a median survival time of about 2 years after discharge from the hospital. And then the long-term mortality was due to non-cardiovascular as well as cardiovascular reasons. So the question is when should the ablation be performed? Let me show our case, 64 years old male, ischemic VF storm, which was managed by the ECMO. Surprisingly, for 2 weeks, he survived 2 weeks during ECMO support. We tried all of the medications and then DC shock many times, but the VF storm was not controlled. So we put the ECMO, and then 2 weeks later, we did catheter ablation here, which was done by Dr. Nogami. And this is the baseline EKG of the procedure, VF on ECMO support. And surprisingly, after ablation of the left ventricular septum Purkinje network, VF terminated. The VF never terminated by the cardioversion, DC shock, or any antiarrhythmic drugs, but ablation terminated the VF, which was for more than 2 weeks. But this patient unfortunately died because of the heart failure and the infection after the ablation. But the patient had no recurrence of the VF after ablation. However, we lost this patient. So this slide shows the number of survivors against the duration from the VF occurrence to the ablation procedure. As you can see, in-hospital death increased when ablation was performed later. The blue bar is the survivor. The yellow bar indicates the in-hospital death patients. So you see the when we do the ablation after the occurrence of the VF more than 8 days, the in-hospital death rate is very high. Of course, this is a retrospective observational study, so we cannot prove anything. But this data suggests that early intervention after the VF storm occurrence may be associated with the reduced risk of in-hospital death. So finally, how to ablate ischemic VF. Before thinking about the ablation strategy, we should understand the underlying mechanism of the VF initiation. We know that most likely arises in the subendocardial Purkinje fibers. There is an extensive experimental support for the arrhythmogenic role of Purkinje fibers in triggering and maintaining the VF. And this review article by Dr. Misha Haisagel, which suggests that the Purkinje system is considered to be involved in the VF, not only ischemic patients, but also in many structural heart disease. In this article, almost always the Purkinje fibers are related to the VF initiation and maintenance. In many structural heart disease, like not only ischemic, but also DCM or HCM or this kind of structural heart disease. This is an example of the VF initiation in patients with hypertrophic cardiomyopathy. This tracing clearly shows the Purkinje potential preceding the ventricular beat during fibrillation. This suggests that the Purkinje network serves as not only focal source of the trigger, but also the reentrant circuit, possibly of the fibrillation. This is our case, 60 years old male VF storm, 1 week after myocardial infarction. After admission to our hospital, we did the temporary pacing and started amiodarone injection, but frequent VF storm refractory to these kind of medications, and we put the impeller and we did the overdrive pacing, but you see the lactate increases, and then we increased the impeller from P5 to P8. Then but the patient hemodynamic stability is worsening. So we did the ablation in patient at day 3. And here is the voltage map of the left ventricle. And then you can see the left posterior fascicle. And then this is the Ripple map. And you can see during sinus rhythm, we see the conduction of the left posterior fascicle like this. And I did the ablation of the Purkinje muscle junction network, because the trigger of the VF may be originating from here, just the distal part of the left posterior fascicle. However, we did the like substrate modification of the VF initiation. This is important paper from Michel, and then I think this is a very important message. They demonstrated that the most activities driving the onset of the human VF arise from the Purkinje network, and then just first initial several beats of the VF is the morphology is very organized, and then few seconds later, this VF is disorganized to the myocardial fibrillation. But this initial part of the fibrillation is just the re-entry of the Purkinje network. So it remains to be determined whether the favorable effect of ablation was the result of the elimination of the trigger or modification of the VF substrate at the Purkinje network. It remains to be determined, but I think that latter is plausible. In fact, in our study, we observed that in some cases VF became non-inducible anymore after ablation, which means that we modify something about at the VF substrate. So ablation of VF substrate associated with the Purkinje network and disconnect the Purkinje network may be effective for suppressing VF. This is published by Dr. Nogami or many doctors, and then we call it Purkinje denetworking. That is the substrate ablation of the ischemic VF. So I would like to summarize my talk. Catheter ablation should be considered in patients who have multiple episodes of VF requiring multiple shocks, which is refractive to conventional therapies and triggered by frequent PVCs. And in those patients, early intervention as much as possible may be better. And since the most activities driving onset of VF arise from Purkinje network, the Purkinje denetworking may be a reasonable strategy of ablation. Thank you very much.
Thank you. That was great. Learned a lot from it. Dr. Komatsu. Now, so I guess my question is from the last slide. How do you Purkinje? How do you target them, and which line, or how do you test the endpoint of it?
Oh, the procedure endpoint is very difficult. That is totally due to at the discretion of the operator, I think. I think, but sometimes we can stop the procedure if the frequent PVC eliminated. But in my personal opinion, not only the elimination of the trigger, but also we extend to some extent the ablation area around the trigger site, because that is the maybe the substrate of the ventricular fibrillation in the initial part. So, but the area of the ablation is depend on the patient condition and also the operator, I think.
So you do both the Purkinje and
Yes.
the foci.
Yeah, correct.
So if the foci is pretty much, if the foci, let's say in the posterior fascicle, you would do ablation, the Purkinje on the lower, the posterior fascicle, not the anterior. That depends too.
It depends.
Okay.
Yeah. But the posterior fascicular region, distal part, is the most common site of the substrate, I think. So that is the main target. Even if the patient had the trigger from the anterior part, we ablate the posterior part and also a little bit anterior part. It depends on the patient, but the posterior region is the main target.
Great. Okay. I think I learned a lot from that. Dr. Lin, do you have any questions?
Yeah, I have a question. I follow from the previous question. So how to decide which part is the key part?
Yeah.
During ventricular
Yeah.
fibrillation.
It's maybe we have to identify the 12-lead ECG of PVC triggering VF as much as possible. It's difficult, but we have to try that to get that. And then if the trigger PVC is originating from the anterior part, maybe the culprit Purkinje network should be the anterior vascular lesion. Yeah.
Thank you.
All right. Okay.
Thank you.
Thank you very much, Yuki.
Thank you.
Okay. Next, Omar Alfonsi. He'll be talking about stellate ganglion block, when and how to use it. He's from Abu Dhabi. Omar, please.
Share my slides. Can you see my slides?
Not yet. Okay, I think it's coming up. All right, great. Thank you, Omar.
Thank you, Chairman, and thank you, the Asia Pacific Society of Cardiology for the invite. I really enjoyed the talks, I think as much as the attendings. So I'm gonna talk about the percutaneous stellate ganglion blockade to treat electrical storms, who, when, and how. And we're mainly focusing on the STAR study, which was recently published in 2024. So I have no disclosures. The objectives will demonstrate available options for cardiac electrical storm management, demonstrate the latest evidence on percutaneous stellate ganglion blockade, mainly focusing on the STAR study, but there were a few interesting studies that I'll mention quickly, and the presence of the automodulation, I would say, not really the specifically the percutaneous stellate ganglion blockade in the guidelines. So we'll go through a quick introduction, some clarification, and then the evidence for the procedure, the available techniques, and a quick conclusion. So as was mentioned earlier, electric storm is a life-threatening condition that is one of our nightmares in EP, and it's defined by 3 or more episodes of ventricular tachycardia or ventricular fibrillation happening within 24 hours. And the management of the electrical storm is extremely challenging, and which we are starting to realize is that electrical storms, when it comes to the EP ward, is actually not that rare. It can occur in up to 5% of patients who have primary prevention ICD, and up to 25%, depending on which study you're reading, in patients who were implanted in secondary prevention. So the traditional treatments are either pharmacological or non-pharmacological. We'll go quickly through what are the recommended treatment measures in the guidelines. So this created an unmet need for additional therapeutic options. Of course, my colleagues talked already about some of them, but we'll talk about the stellate ganglion blockade. If we see on the central graph that stellate ganglion stimulation can actually in some result in ventricular arrhythmias. And we know now, and there is growing evidence that when you have structural heart disease, there's remodeling that's happening on all the neuroaxons, starting from the brain to the stellate ganglion. And this results in a positive feedback on the cardiac sympathetic afferent reflexes, resulting in ventricular arrhythmias. So we'll quickly try our best to treat the reversible causes, do ICD reprogramming, maybe sedation, up to general anesthesia, circulatory supports. But when everything else fails, we needed something extra that we can offer this patient. And this might be stellate ganglion blockade for them. So as we mentioned, the electrical storm management, actually all the guidelines, European, Americans and Canadians, they actually recommend autonomic modulation at 1.4 VT/VF electrical storm management. So the steps, we normally start by reprogramming in case of inappropriate shocks or lead fractures, ICD abnormalities, or maybe to relieve the amount of shocks that the patient is relieving. Introducing drug therapy, including all the medications that my colleague already mentioned. Sedation up to general anesthesia, of course, catheter ablation and autonomic modulation. And definitely if the patient is not responding, mechanical support. So let's focus on our study. So it's a multi-centric international retro and prospective observational study that managed to, it happened over in 19 centers and managed to come up with up to 133 patients. 2 of them were excluded for incomplete charts. So that was the flow of the study. They managed to enroll 133 patients who underwent 186 percutaneous stellate ganglion blockade. It ran between 2017 and 2023. As you mentioned, 2 patients were excluded because of incomplete data. So their endpoints was the effectiveness, the primary endpoint or outcome, I would say, was the effectiveness of percutaneous stellate ganglion blockade and reducing by at least 50% the number of arrhythmic events, which was measured by ATPs and shocks received by the patient. And they compared the immediate 12 hours prior to the intervention and 12 hours after the intervention. They had few secondary outcomes where they were comparing the immediate amount of ATP and DC shocks, as we mentioned. They measured the complication, the presence of asymmetrical pupils, where is the classic sign of effectiveness of the stellate ganglion blockade. And they also compared the anatomical approach, whether it mattered if you did an anterior approach or a lateral ultrasound guided approach. And they compared a single shot compared to continuous infusion, and whether it mattered if you work in a high volume center, and they defined the high volume by centers who managed to recruit more than 20 patients compared to low volume centers where they managed to recruit less than 20 patients. Of course, their technique, as you mentioned, they used either an anterior anatomical technique where the landmark was on the left side of the chest tubercle at the level of the C6, or the ultrasound guided technique with an injection on the longus colli muscle just beneath the carotid artery. Of course, the choice of the type of anesthesia was left for the operator, and the technique was also, the choice of technique was also left to the operator. They prefer to start with a left-sided injection, and if that was not effective after the predicted time, then a right-sided attempt was also allowed. So a quick diagram on both techniques. So we see the anterior approach is mainly anatomical, where you would displace the sternocleidomastoid muscle and you go over the tubercle, and the ultrasound guided technique approach, which I found extremely interesting, is that the operators were actually trained for a course of 8 hours, which in my opinion was a very quick course to acquire this technique. It consists of 4 hours theory and 4 hours of practical training. But these operators, of course, they knew the technique from before, but 8 hours course was pretty quick in my opinion. So when you look at the baseline characteristics, mainly we were dealing with the male patients. Of course, they were sick with a left ventricular ejection fraction around 25%. The majority received an anterior anatomical approach compared to lateral ultrasound guided. And of course, the majority was tried on the left side. Some got right-sided blockade, and most of them received the bolus. And as we expect, the majority were ischemic with dilated cardiomyopathy as a cause for the electrical storm. A very interesting table was the complication rates. The major complications were reported in a single patient. The rest of the minor complications, including bradycardia, hypotension, were reported also in a very small number of patients. So the procedure is actually quite safe. When it comes to outcome, we can see the immediate reduction in the if we go by per patient analysis or per procedure analysis, there's a significant reduction in the arrhythmia burden. They reported 92% of patients had more than 50% reduction in the amount of or the burden of the arrhythmia. And in some patients, it resulted in a complete resolution of the arrhythmia. So the summary slide of the study, as we mentioned earlier, 19 centers, 131 patients were analyzed, 184 procedures. And the impressive results of 92% of these patients showed reduction of more than 50% in the 12 hours after the percutaneous stellate ganglion blockade. Only one major complication. The secondary outcome, there were not significant differences when it comes to the presence or appearance of the asymmetrical pupils. Whether you use the bolus or used an infusion, whether you used an anterior approach or a lateral ultrasound guided approach, or whether you were on a high or a low volume center. all did not play a major role. This technique was safe and it was effective. A very interesting sub-analysis of the same study actually showed superiority of the technique when it comes to the VF and the fast VT. The technique was more effective in terminating the arrhythmias compared to the slow VT. So other studies all were recently published in 2024. This was in Nature Scientific Reports. It's a meta-analysis combining multiple studies, and it did show what was already noticed in the STAR-AF, that percutaneous stellate ganglion blockade actually does result in a significant amount of reduction or even termination of the ventricular stone. A similar study, which was carried out in the United States, and I think it was in Duke University, and they showed again a similar result of effectiveness of the percutaneous stellate ganglion blockade in controlling the VT or VF zone. So the guidelines, unfortunately, for management of VT are a bit outdated when it comes to the recent evidence that we have in 2022. But even at those times, we can see when we're dealing with a polymorphic VT storm and the causative was a LQT or a CPVT, we have a class 2A to go for autonomic modulation. And when it comes to ventricular arrhythmias and monomorphic ventricular arrhythmia, it's a class 2B, and the same class applies for STEMI patients as well. So to answer the question that was asked, I think it's with the data that we have and the observation studies that we have, it's for management of patients with electrical storm and who's having fast VT, VF, when everything else has failed, to make it simple. So my conclusion, the management of electrical storm is extremely challenging and carries a high risk mortality rate despite all our efforts. Percutaneous stellate ganglion blockade approach and electrical storm management seems to be effective and safe. Percutaneous stellate ganglion blockade approach and electrical storm management can be considered when all other modalities fail to control the arrhythmia. Unfortunately, the lack of randomized controlled trials yet is preventing a stronger recommendation in the guidelines. And percutaneous stellate ganglion blockade technique and drug use did not seem to impact the effectiveness of the procedure. And fast VT and VF seems to respond better for percutaneous spontaneous stellate ganglion blockade. Thank you very much. I'll be happy to
Omar, that was great. I don't have a question yet, but maybe Dr. Lin can come up with a question. I have a little comment. Actually, in Thailand, we've been using a lot of stellate ganglion block for a long time. My boss, Dr. Lin, he actually published this one of these papers a long time ago. So actually, we use it a lot earlier than what's recommended, because basically it can be done bedside in the CCU. So we actually get done even before other things. Because by the time you want to set ablation up and do all these things, you can get the stellate ganglion done much quickly, and a lot of time it just aborted the VT storm. If you don't have a lot of experience with it, at least from our part, what we do is we get the anesthesiologists. They are quite familiar with it, especially the pain team. They do it a lot for some chronic pain. So that's my comment on it. But actually, cost wise and availability, it's actually much easier to get these things done. What's your thought on it?
Excellent. And Honestly, I haven't been doing it myself. Normally, as you mentioned, we send them to anesthesia and to intervention radiology, actually, and they are the ones doing these interventions. It's quite effective. I've done it in a long QT patient, and the result was miraculous. Like the storm just terminated. I totally agree with you. It's readily available. And honestly, managing an electrical storm, you're doing multiple things at the same time. So
Right.
yeah, you're preparing this, you're preparing for ablation, maybe for ECMO, that the patient is really unstable. So this is definitely one of the things that we can do quickly and effectively.
Comment from you, Dr. Lin.
Yeah, I have one. So you do the bilateral static ganglion blockade or only unilateral? I mean, about the literature.
You do it on the left only. What's the trial? I don't recall.
Honestly, as I mentioned, it wasn't us actually doing the intervention. It was the anesthesia guy who did the intervention, but they used an ultrasound guided technique. Like they went with ultrasound. And I believe it's the lateral approach rather than the anterior anatomical approach.
Mm-hmm. Yeah, because we have two stellate ganglion. So maybe bilateral stellate ganglion blockade is needed in most of the cases, I think.
I think I read up on this, but I kind of forget. I think there's a reason. There was a good reason that we started with the left first, and if it works fine, then you could just stick with the left. And if it recurs, you can actually repeat it again on the left side. I guess I recall the one patient that we actually did on two sides, but most of the time, I think you get away with just doing one on the left.
Okay, thank you.
Wait, okay, I guess we are running out of time. So Omar, thank you very much. Next up is Dr. Ho. Lin Ting Ho. She will be talking about the reappraisal of defibrillator as a primary prevention. Dr. Ho is an attending electrophysiologist from National Taiwan University. Dr. Ho, please.
Thank you, Chairman. Let me share my slide first. Okay. Good afternoon, ladies and gentlemen. I'm Li Ting Ho from National Taiwan University Hospital. And today my topic is to revisit the ICD indications for primary prevention of sudden cardiac death in HFrEF patient with optimal goal-directed medical therapy. And there are many key trials for the primary prevention of the sudden cardiac death in the HFrEF patient. In the beginning is the MEDIT and the MEDIT-2 since 1996 and enrolled the post-myocardial infarction low EF patient. It means the ischemic cardiomyopathy and ICD showed a significant benefit in this kind of patient. And then is must try in patient with CAD-EF less than 40. EP-guided ICD implantation also showed a benefit. However, in 2003 and 2004, the IRIS and the Dynamite trial failed to show the ICD benefit in post-MI less than 40 days patient. So in the current guideline, after myocardial infarction, after 40 days, we are considering the ICD, but less than 40 days, maybe the medical therapy will the best choice. And then they started for the non-ischemic cardiomyopathy from the definite Scott Heft and the Dennis trial. And it shows that ICD still showed benefit in a patient with non-ischemic cardiomyopathy. And the current recommendation for ICD in HFrEF patient still mention that the EF symptomatic heart failure patient with EF less than 35 and also in ischemic or non-ischemic cardiomyopathy, or asymptomatic very low EF patient, less than 30, and maybe less than 40 with EP guided, or cardiomyopathy due to other cardiomyopathy such as sarcoidosis, ARVC. And their class 3 recommendation for ICD included advanced heart failure and who are not candidates for the advanced heart failure therapy, or multiple comorbidities, too fragile, or the life longevity is less than 1 year. However, when you see all the trials of the ICD, we can see that there are greater absolute risk reduction in the earlier trials, but diminishing benefits observed with ICD in more complementary studies. In 1996, the method showed that ICD can reduce 23% of mortality. However, in the method 2, only 6%. And in the latest Danish trial for the non-ischemic cardiomyopathy, only 2% reduction of the mortality risk. So why? I think that due to the background medical therapy. We can see that in the MEDIT trial, there are only less than 30% patient had beta blocker, and only 60% patient had ACE inhibitor or ARB. But in the later trial, the beta blocker and the ACE inhibitor prescription rate will be higher. But the MRA before the 2016, there are no patient had MRA in the study. But in the later study, only 60% patient have MRA. And now we recommended ARNI and SGLT2 inhibitor in the HFrEF patient. And these ICD key trials never enrolled patient with ARNI or SGLT2 inhibitor. So, and the most updated HFrEF recommendation, the higher optimal 4 pillars of guideline-directed medical therapy included ACE inhibitor or ARNI, beta blocker, MRAs, and SGLT2 inhibitor will lower the sudden cardiac death risk. If the patient had all 4 pillars of the medical therapy, the residual sudden cardiac risk will down to 5.9%. But unfortunately, most patients are not receiving optimal dosing of these life-saving medications. And according to previous registry of the CHAMP-HF, we can see that the ACE inhibitor, ARB, and ARNI prescription rate is only 70%, and the beta blocker only 60%, and even the MRA is only 30%. So I think most of the HFrEF patient didn't have optimal guideline-directed medical therapy. Otherwise, if the patient had a prescription, the dosing is not adequate. You can see that most of the dosing, either the ARB, ARNI, ACE inhibitor, beta blocker, or MRA, is less than 50% of optimal dose. So I think that if the guideline-directed medical therapy can be rapidly initiated and titrated to optimal dosing, perhaps ICD implantation can wait until further assessment of LVEF. And with the improvement of the EF, fewer patients will meet the current criteria for ICD implantation. But why? Why we didn't prescribe optimal dosing of the guideline-directed medical therapy? And in the CHAMP heart failure registry, the reason why we didn't titrate it up the dosing due to the physician thought that the patient was in clinical stable. So we thought that the patient is in clinical stable status, so we keep on the current dosing and not titrate it up to the maximum tolerated dose. And according to previous studies, we know that the drug protection effect is higher in the maximum dosing rather than the lower dosing. So, and this registry, we can think about if we are titrating the medical therapy as much as we can, And if the patient is still in stable status, we still have to titrate up the dosing to make the best benefit for the patient. So even the patient got ICD, if we have optimal medical therapy, in this study, we show that if there are no optimal medical therapy to 3 to 4 medical therapy, we can see that the outcome, the survival, will be better in patient with a much more optimal medical therapy. So even in patient with ICD, the medical therapy in optimal dosing and optimal categories can still show benefit in these patients. But how about the ICD in patient with already have the optimal medical therapy? 20 years ago, the methods showed not adequate medical therapy, and ICD showed significant benefit. But in the recent studies, we can see that the medication is achieve around 70 to 90% of medical therapy prescription, and ICD groups still show the benefit in these kind of patients. So I think either the medical therapy or the ICD or both have the significant survival benefit in the patient with HFrEF. However, not every subgroup showed a similar benefit. In the subgroup analysis, we can see that older age or the patient with diabetes may have neutral, not so beneficial from the ICD, but otherwise, others, the younger patient, either ICM or DCM, or either high-risk group or low-risk group, either the functional class or region, and male-female don't have any difference from the ICD benefit. And in the paradigm heart failure, it is the latest, one of the latest HFrEF study, and the patient is in relatively optimal heart failure medication. And we can still show that in patients with ICD at baseline or not ICD, and ICD still have reduced the sudden cardiac death risk. And in patients with beta blocker, MRA, and also the RNA patient, the ICD still showed survival benefit. There's all kinds of subgroup patient. So we have to do our best to let our patient have the optimal dosing of the goal-directed medical therapy, and also suggest patient to receive the ICD for the primary prevention as the guideline suggestion. However, in Asia, I think that the prophylactic ICD is underused. And paradigm heart failure, the primary prevention ICD implantation is around 54%. However, in the Asia Pacific, it's only 1.7%. It means that 90%, more than 90% of patients is eligible for ICD, but without ICD. And in the Asian heart failure registry, we can see that Japan is the highest rate of primary prevention of ICD. However, in other countries, less than 20%, and even in less than 10%. And compared to the Europe, 24%, and compared with United States is 30 to 50%. And I think that higher ICD prophylaxis use is directly related to the higher socioeconomic and the national economic status. And the lack of the knowledge about the device was a barrier to patient acceptance of ICD insertion. Like in Taiwan, the health insurance only reimburses the patient with secondary prevention for ICD implantation. And for primary prevention, only very selected patients can have the insurance reimbursement in Taiwan. So I like it due to the national economic status. And in the United States, in North America, also not every patient eligible for prophylactic ICD have ICD implantation, and it is due to the acceptance of the patient. So in Taiwan, I think that not so many patient is willing to have prophylactic ICD implantation in Asia or in Taiwan. And I think that is one of the goal for us to have more health education about this one, and to suggest patients to have prophylactic ICD to improve the survival and reduce the risk of sudden cardiac death. And I think that there are several other reasons that in Asian country, the ICD prophylactic rate is so low, because in the previous study, the VF-related OCA is the lowest in Asia compared with Europe and North America. So maybe the sudden cardiac rate is not so high in Asia country rather than the Western country, and also the lower rate of ischemic cardiomyopathy in Asia country. So I think that there are two other reasons causing the ICD underutilization. But I think that if the national economic condition is better, and better physician awareness and the patient awareness of the ICD prophylaxis, I think the primary prevention of ICD will be higher in the future. So let's revisit the latest ICD implantation guidelines, and it is just published in January 2025, and show that tell us the appropriate use of criteria for the ICD. And for the primary prevention, first of all, is the post-myocardial infarction. If the post-myocardial infarction is less than 40 days, but the EF is less than 40, we have to be very careful. If the patient is not revascularized, we can see the EF. If it's extremely low EF, less than 30%, maybe ICD prophylaxis will be beneficial. However, if the EF is 31 to 40, the guideline doesn't suggest it, the ICD implantation. And we can do the EP study. If the EP study show the inducible VT, I think that the ICD prophylaxis is very appropriate. If not, we still have to considering the indication for these patients. And if the patient got revascularized, I think that we have to perform the EP study to show if there had inducible VT. If yes, we are considering the ICD implantation. If not, it is not appropriate for the ICD implantation. And for the ischemic cardiomyopathy after MI, more than 40 days, I think almost every patient should considering the primary prevention of ICD implantation. Unless the patient is not so low, the EF is 36 to 40 without inducible VT-VF and is asymptomatic. Maybe it is not appropriate, but otherwise, the other patient should considering the primary prevention of the ICD. And for the non-ischemic cardiomyopathy, we have to see if the patient have received the goal-directed medical therapy for more than 3 months. If not, we have to wait for the medical effectiveness. If the guideline-directed medical therapy were prescribed more than 3 months, we can recheck the LVEF. If the LVEF is improving, but the MRI showed significant late gadolinium enhancement, we still considering the ICD implantation, because if the substrate is very diffused, I think that will be high risk for the further sudden cardiac death. And if the LVEF is not improving and the patient is not so old, less than 84 years old, I think that primary prevention of ICD is indicated. And even if the patient is older than 85%, but the patient is well-being, and ICD is considering to be beneficial. Any other non-ischemic cardiomyopathy but have other structural disease such as choroidosis, amyloidosis, or ARVC, I think that, or genetic disease, I think that they are in high risk of sudden cardiac death, and the primary prevention should be considering. In a genetic condition, I think that hypertrophic cardiomyopathy, ARVC, Lamin mutation, we have to considering the risk of the sudden cardiac death. Even they are more risky other than compared with ischemic or dilated cardiomyopathy. So primary prevention is very important. And we have considering the rarely appropriate is not appropriate in patients with multiple comorbidities, life expectancy less than 1 year, and maybe too old, more than 90 years old, or other infection consideration, or stage 4 heart failure. I think that ICD prophylactic will be rarely appropriate. So here is my conclusion. I think that medications are very important for the sudden cardiac death prevention, but so is ICD. So both we have to do our best for the patient. And the underlying etiology matters. Patient with ischemic cardiomyopathy may benefit from having ICD more, but despite of the effectiveness of the medical therapy in non-ischemic, ICD still plays a crucial role in reducing the risk of sudden cardiac death. And if the patient have HFrEF with other arrhythmogenic cardiomyopathy, it significantly increases the risk of sudden cardiac death. So the prophylactic ICD should be considering at the first time. And in Asia, I think the ICD is underutilized, and it is due to socioeconomic status and the national economic status, and also the physician and the patient lack of the knowledge about the device therapy will decrease the utilization rate in Asia. So I think that we have to improve our patient knowledge about the device therapy, and after the economic status can be for the primary prevention of ICD, the implantation rate in Asia will be more and more, and we can provide better outcome for the patient. Thank you for your listening. Thank you.
Thank you very much, Dr. Ho. That was very detailed talk. I enjoyed it a lot. Yes, I agree. It seems like now the rate of ICD implant, even in Thailand, where we actually have good reimbursement, are going down. And it's probably a few reasons. It seems that I think maybe even with earlier intervention with the coronary, with primary PCI and things like that, so that less people having bad heart with big scar. So we are seeing less patient with really bad heart. And I think with the new heart failure guidelines, I think that's actually make a lot of people wait. And you could see sometimes that the heart gets really better. And it seems like we have less defibrillator to put in. But yet, having said that, yes, I think overall we are underutilized ICD big time. As far as question concerned, I don't think I have any. Dr. Ling, you have any question or comment?
No. Yeah, but I think that yes, ICD implementation is actually an economy problem. It's an economy problem.
Yes. I don't know. I think because Dr. Ho was mentioning about age, I think that's important things. And a lot of times I think maybe I would actually push more for like younger patients who still actually, at the head of the family, where he is earning his work. So I think in those group of patients, sometimes I would actually push quite a bit more to go, because I think it's not only saved the patient's life, it saved the whole family's life. So
yeah, I agree with you. I agree with you. We also have to consider about the complication of ICD. Yeah, as we can see the lead fracture, the pocket infection. We have to use leg extraction for some patients that also carries high risk. So yeah, it depends.
Right. Well, you can do SICD. That costs even more.
Yeah. But
Yeah.
I think in younger patients, maybe 40 years old, less than 40 years old, and do not have the indication for pacing, SICD or EV-ICD right now may be a good choice to avoid the long-term lead complications, because if the patient can live till their 80s, I think that the ICD leads cannot lasting for 40 years. Yeah, so maybe in the beginning, use the subcutaneous or EV-ICD, and maybe after 60, they can receive the transvenous ICD. Yeah.
in Thailand, those who can afford SICD is actually older patients. Younger patients cannot afford SICDs.
Quite ironic.
It's like almost 3 times more expensive.
Yeah, 3 times.
3 times.
All right. I guess it's about time. Thank you very much for all the speakers. Dr. Lin, thank you for the invitation to join. I think this is a very good talk today. I've learned a lot. I hope everyone else also enjoy and learning as much as I do. And I guess looking forward to the next APSC in the future. Yes, wait, no, I thought you're going to have the next one coming up. Okay, all right. Everyone, thank you for joining us. I'll just call this session to a close. Thank you, everyone, for giving a talk and listening in. Thank you very much. Goodbye.
Thank you. Bye-bye.
Bye. Bye. See ya.
Take care.